Hello.
Morning.
Welcome to our May webinar. So as May is Stroke Awareness Month, we thought we'd focus on maximising recovery through specialist seating.
Yeah.
My name is Les Jones and I'm joined by my colleague.
Rebecca Dunstall, hi.
Rebecca's our clinical lead and a physiotherapist. The makeup of today's session is much the same as our usual. It's going to be a mix of PowerPoint and some kind of live hands-on case study with one of the chairs that we have with us today. So if I leave Rebecca
Thank you.
to load her part of the presentation. Housekeeping, we are recording the session. So your mics and your cameras should be switched off. If you've got colleagues who can't make it and would like to see the presentation, we can send you a link to the presentation after we finish. We'll also send you copies of slides and case study notes as well. In the background today, helping us is Jess, our colleague. If you have any issues or queries, if you'd like to post them in the chat feature, we'll try and pick things up at the end of the session. If you have a technical issue, what we tend to find works best is just exit the meeting and rejoin the meeting. It seems to reset the connection and it clears up most issues. So without any further ado, I'll pass you on to Rebecca and I shall see you in about half an hour or so.
Thank you, Les. Okay, as Les said, yes, our usual format, we'll have a look at the theory behind stroke, why postural care might be important and how specialist seating fits into that. We just wanted to play our part really in highlighting how stroke can impact on individuals and their ability to be able to achieve their optimum protective sitting postures. And then, as Les said, at the end, to give you some practical advice then, consolidate that knowledge, have a look at some of the seated solutions that might be help with some of the postural challenges we might find with the individuals we work with who have experienced a stroke. Now, just to set the scene, so a stroke or a cerebrovascular accident, commonly known as a stroke, is a serious life-threatening medical condition that happens when blood flow to the brain is restricted or stopped. And like all organs around the body, the brain needs this vital oxygen and nutrients that's provided by the blood to function properly. Lack of oxygen and lack of nutrients can result in brain cell death, which can then lead to the brain injury that we see, the disability and possibly even death. The brain controls various different bodily functions, and if those brain cells die in a particular part of the brain, then the body function that area is responsible for will not function as normal. There are different types of strokes. So ischemic strokes are the most common, so around 85% of all cases, and this is where the blood supply is stopped because of a blood clot or a narrowing of an artery. And then you've got hemorrhagic strokes where there's a weakened blood vessel that burst, also known as an aneurysm. Now, strokes in the UK happen every 5 minutes, and there's around 100,000 people every year who experience one, which means there are currently 1.3 million stroke survivors in the UK. The effects of a stroke can be devastating and the body needs time to heal and recover. For some people that we work with, those effects may be minor and short-lived, but others may be left with more serious problems that are related to things like mobility and independence. The injury to the brain that's caused by a stroke can lead to widespread problems, and that it can also be long-lasting. And although some people can recover quickly and return to normal function, many people will need that long-term support to help them regain their optimal independence, so get as much independence as possible as part of their recovery journey. And that rehabilitation will depend on the effects, the location of the brain injury and the severity. Some of the common effects that we can see are things like psychological impacts, fatigue, cognitive communication problems, physical problems, which we'll cover in a bit more detail as we go through this morning, swallow problems, incontinence and pain. Now, most people will have some problems with movement after a stroke. And the main cause are things like muscle weakness, which can affect the ability, of course, to move the body, to move the muscles and the body segments. In severe cases, some individuals may present with paralysis. Other challenges that can impact on those movements include abnormal muscle tones. We might see things like spasticity, foot drop, which of course then lead to mobility problems, reduced balance, sensory impairment, so proprioceptive feedback, not knowing where the body is in space, and even reduced stamina. In terms of stroke recovery, stroke care requires an appropriate environment. And there's some, as we said, we'll give you the presentation slides and there's a reference list at the end. But this is just really good justification for providing appropriate postural support and of course pressure redistribution that comes with that, and easy access to aids for rehabilitation, which includes chairs of the correct height. So that's quite specific, but when we go through the seated solutions later, you'll see why that's key, and all those other seating solutions that protects the body segments. So the aim is to promote optimal rehabilitation by increasing postural awareness and protecting those body segments, modulating muscle tone to encourage as normal functional movement as possible, and trying to manage any abnormal movement patterns. Giving the individual the sensory information, increase that stimulation, especially if there's an affected side. And of course, ultimately preventing any secondary complications. Now, postural care fits into this because it's really key that we address the individual's posture across that 24 hours to enhance their recovery. 24-hour postural care is a whole webinar in itself. If anyone wants to learn more about 24-hour postural care, what we actually mean by its definition, and how we can maximise care plans, then just pop it into the chat and we can share some webinars that we've done in the past, and some links to the website as well. It's got a bit more information on there about 24-hour postural care. Of course, we're going to be focusing on the specialist seated aspects of the seated posture today, but we do need to address that full 24 hours. To make sure that we are targeting the body segment in all postures and positions. It's believed that many postural challenges begin in lying and are then compounded in sitting. So to be able to maximise seating during the day, we need to look at nighttime positioning, for example. If we don't provide appropriate equipment, then we can delay stroke rehab and limit that final level of independence that somebody can achieve. Now, postural care in the simplest of terms, is defined as the holistic use of any technique that we do as health and social care professionals to minimise posture and abnormality whilst enhancing functional movement. And it's an approach that aims to preserve and even restore body shape for individuals with movement difficulties, and of course individuals who have experienced a stroke. Now remember, the body distortion, even with individuals with really complex postural challenges and movement disorders, it's not inevitable, and with the right equipment and positioning techniques that are put in at the right time, we can protect body shape. Of course, a big part of this is pressure care as well, because posture and pressure are inextricably linked. Body positioning has a direct influence on the pressure going through specific body sites. The problem is the body can only withstand these high interface pressures for a very short period of time. And if that loading of the tissues is unequal, or if the pressure isn't regularly redistributed, then that's when pressure ulcers happen. And when they do happen, as we know, they can have profound impact on overall well-being because they're both painful and debilitating. Now, a key intervention for pressure injury prevention is that redistribution through regular repositioning, because that's believed to be one of the most effective methods for preventing skin damage. And then as we look at a case study later in some of the seating solutions, you can get an idea of how we use specialist seating as part of that postural care and pressure care programme to encourage pressure redistribution within the chair. So where does specialist seating fit into stroke recovery? Now, it can offer individuals a solution for balancing key considerations for effective postural care. And these are the three different areas we're going to be focusing on. So we've got comfort, which is ultimately about the compliance, but also consistency. Energy conservation, so thinking about the individual's engagement in rehabilitation and daily living. And then function, increasing their independence and protecting their health and well-being. Now, prolonged or destructive sitting postures, which we can see in individuals who have experienced a stroke, can cause tension on those body segments. And what this can do is increase the risk of significant secondary complications like exacerbated pain and postural deterioration. Proper positioning has been shown to help alleviate that chronic discomfort and decrease fatigue. Now, a direct goal of this would be that if an individual feels comfortable and feels safe within the piece of equipment, then we can increase their tolerance of that desired seating position and compliance with the piece of equipment. If an individual isn't comfortable, then they may not use the chair regardless of the clinical benefits, and that's why a CareFlex comfort is our top priority, because it essentially dictates the effectiveness that we get out of specialist seating. So we don't want to negate all the hard work we do as part of our assessment and prescription if the individual is simply not going to use that piece of equipment. So we need that compliance, we need them to be on board with the piece of equipment for us to be able to achieve our clinical objectives. Fatigue comes into this and can play a big part in comfort as well, because it can often be experienced following a stroke and affect all aspects of an individual's life. What we can see is unsupported postures cause fatigue because of inefficient use of the body structure. And then you've got that added impact from gravitational forces that can make it really difficult for those with muscle weakness and paralysis or abnormal muscle tone to remain upright and rigid against the effects of gravity. When fatigue happens, it will significantly restrict their ability to engage in daily living, which of course will have an impact on them psychologically and socially. Another thing to be wary of with fatigue is that it is associated with other significant postural challenges as well. So if we don't manage fatigue, if individuals, then we start seeing unequal loading of the tissues, we see the head rolling, the body slumping, falling asleep in chairs and not being supported adequately. What we can see then is the development of things like contractures, kyphoscoliosis, which of course are then quite complex posture challenges that we'll need to address within the chair, when ultimately what we want to do is to have energy conservation plans in place to manage and put strategies into daily life to reduce the impact and the probability of those becoming chronic issues. So by using the specialist seating appropriately, we can encourage that energy conservation. When we have a look at the seating solutions, we can talk about things then like tilting space that can really help to offset some periods of fatigue, if it's appropriate, before coming back upright to engage in a meaningful life. And the third priority we mentioned was function. Now, going back to 24-hour postural care, that's fundamental to functional independence. Individuals need that function to be able to participate in activities that are important to them. It allows them to access their environment, and it allows them to engage with the world around them, with family members, with loved ones, in hobbies, in occupation, and so on. So it's critical to independence and is an important factor in living a fulfilling life, especially when it comes to things like well-being and stroke recovery, and being motivated and achieving goals is a really key part of making sure that we maximize that recovery process. When we talk about function, there's three different areas, really. We've got the functional movement, the physiological function, but also the functional engagement. Now, the first one, functional movement. If we sit in supportive sitting postures, research has shown that it can be effective in inhibiting any abnormal muscle tones that we might see with individuals who experience a stroke, and in accommodating any of those secondary attributes. Freedom of movement in the upper limbs is achieved when we have effective stabilization of the pelvis and trunk. So that distal control is underpinned by that proximal stability. So if we work with individuals who lack that pelvic stability, that postural stability, for example, they're unable to maintain this sitting balance, they'll naturally seek to provide that stability through their upper limbs. So what happens then is that they start clinging onto the arms of the chair, or you see elbows digging into the corners, and the hands are then made unavailable to engage in task performance. So we really had to take it back to that pelvis. It is the foundation. And when we look at the seating solutions, again, lots of different aspects of pelvic stability that we need to address to make sure that we get that postural stability so the upper limbs are free from that low bearing role and able to engage in functional movement. Functional movement is also important to protect the body and reduce the risk of injury as well. We need that movement for blood flow and activation and lengthening of muscles, because if we have prolonged sitting, as we know, we can lead to pain, but we can also then see things like soft tissue shortening and even bony changes with contractures that are sadly irreversible. So it's really key to get people moving, increase activity, and protect the body structure. Then, of course, we have physiological function. So if an individual is unable to maintain an upright sitting posture, then research has shown that there's a correlation in a decline in health. Unsupported postures, what we can see then is physiological dysfunction and even premature death. Trunk asymmetry and poor head position can impair things like respiration, so somebody's breathing ability, cardiac efficiency, their swallow function, so safe eating and drinking, and even digestion. Those destructive sitting postures that we can see in individuals who have experienced a stroke can cause organ compaction. What we can see is the head flexion, rounded shoulder girdle, impacting on lung expansion. This can then adversely affect their eating and drinking and making it potentially unsafe, especially with individuals who also then have dysphagia, as we mentioned about swallow problems. What we can see in individuals then is an increased risk of pressure injuries, infections, things like recurrent respiratory infections because of aspiration, choking risks, digestive problems, and then at an increased risk of hospital admission because of ill health. Now, it's believed that 1 in 5 of individuals who experience an ischemic stroke experience dysphagia, so swallow problems, and 1/5 of these are then likely to develop pneumonia. And evidence suggests that stroke-associated pneumonia is a main cause of post-stroke mortality. So this is, again, clinical justification-wise, some good evidence for you to utilise if you are struggling to get a piece of equipment, if you need to justify why specialist seating might be needed over standard armchairs to support trunk alignment, for example, to support head position, to make sure that meal times are safe for the individual. It's also worth noting as well, and we'll cover it a bit later, that there are certain functions that we need to be mindful of with individuals with dysphagia. So back angle recline and tilt in space may not be appropriate for them. And we probably need advice from speech and language therapy to utilise those functions safely, because there might be particular angles, tilt angles, for example, that are unsafe, or there's a period of time after meal times that they need to remain upright. So just to be mindful of that. Now, specialist seating can provide individuals with that necessary postural support for an upright sitting position to try and get that trunk symmetry to reduce that risk of decline in health. If we have good protective sitting postures, we can increase the ability of the body's organs to work more efficiently, which will, of course, help with physiological functions. We can help with normal swallow patterns. We can also help improve components of eating and drinking behaviour. So again, some good references there for clinical justifications if you need that evidence.
Okay, so basically the toilet frame
to support that funding request. And then last, we have functional engagement. So you really cannot underestimate the importance of promoting the psychological and the cognitive factors in an individual's stroke recovery. If an individual has the inability to sit out, what we can see is them becoming confined to the 4 walls of their bedroom with limited opportunities for interaction and engagement. Those destructive postures can restrict them from completing social and psychological functions. And then research has shown that we can see a reduction then in things like their self-worth and their quality of life. Now, it's believed that loneliness and social isolation is actually twice as harmful as obesity is to physical and mental health, which is quite astonishing. So what we can do is utilise specialist seating to encourage this stable posture, to help with participation in social activities, Of course, head control is going to be essential for orientation, for interaction, to help with communication skills, especially with individuals who are recovering from stroke, who may be working on that, who may have lost some of their communication abilities, and is something that they are striving to work towards. Or even if the recovery is limited, then we need to try and utilise specialist seating to support the new communication methods. So, for example, maybe they need trays for PEC systems, maybe making sure that it's compatible with eye gaze equipment and so on. Supporting individuals so that they line of vision, they can get good eye contact with people. So it's just thinking about how we utilise the chair for communication as well as the postural support. When we talk about function as well, and we said there about obviously an individual's well-being as part of their self-worth and motivation and their engagement in recovery. If they stay active, it has been shown that they can not only improve their health, but also their cognition, their confidence and their mood, which is really key part of recovery, to get them actively engaged in that process and motivated to want to continue. I just thought I'd spend some time just looking at some of the cost effectiveness as well. It's something we always get asked about in terms of clinical justifications and long-term cost effectiveness and trying to get the funding in place. It's probably interesting to know that the mean cost of new onset stroke is around 45,000 in the first year and around 25,000 in subsequent years. So if we can justify interventions that are aimed at rehab, to reduce new and recurrent strokes, then we're likely to yield substantial benefits to the individual, to the carers, but also cost savings to society as well. Obesity, as we know, can increase the risk of stroke and other serious health complications. And physical inactivity and obesity has been shown to cost the NHS almost £1 billion and £5.1 to £5.2 billion respectively. So specialist seating should always be utilised to promote functional movement, enable safe transfers, encourage activity. And again, when we look at the case study shortly, you'll see why that's important. Contractures as well. So as we know, individuals who have experienced a stroke, who may present with hypertonicity, with spasticity, with abnormal muscle tone, with muscle weakness or even paralysis, that prolonged destructive postures, we can see soft tissue shortening, the risk of contractures happening. Now, the estimated cost for inpatient treatment for surgery for a single contracture is around £18,000. So if we can be a bit more conservative with our approaches to preventing and managing contractures, and we can use specialist seating for corrective purposes, and think of it as an orthotic device. So again, just to remind you, body distortion isn't inevitable. So if we get the right equipment into the right time and encourage that regular change of position across the 24 hours, we can reduce the risk of these things happening and ultimately cost saving as well. So in terms of the offset price of a chair compared to then the ongoing need for surgery for contractures as an example. And let's bring it back to why we're all here, really, the human cost, taking it back to the individual and why we do what we do as health and social care professionals. We want to promote comfort. We want to think about energy management, encourage functional independence through postural care, because it's a critical part of their recovery following a traumatic health event. We need to protect their body shape, think about that postural stability and enable them to engage in activity, because it's really important for their health and well-being. And remember that optimum postural care throughout that full 24 hours is key to enhancing an individual's recovery. So if there's anything you needed to know more about 24-hour postural care, as I said, pop in the chat function and we'll share what resources we can. I think our last webinar that we did on nighttime positioning and supine positioning was with Simple Stuff Works. I think that was last September, October, I believe. So again, we can share that link if you wanted to learn a bit more about nighttime positioning and supine lying positioning as well, just to make sure that we are matching up daytime and nighttime and really maximising those posture and repositioning techniques. And as always, when we think about complex cases, some individuals that we work with do rely on the support network, whether that's family members, loved ones, or professional paid caring, nursing homes, care homes, rehabilitation settings, and so on. If we have safe and appropriate specialist seating prescription in place, we can also support them as well. We can support the support network, reduce the dependency, reduce that carer effort as well. Because ultimately we might be relying on them to follow that care plan, so they have to be compliant as well. So let's look at George, and so we can really try and put all this into practice and apply that theory of postural care and specialist seating, and look at maybe some of the seating solutions that can help maximise recovery during stroke rehab. So this is George, outgoing 52-year-old gentleman, lives at home with his wife now following a stint a stroke rehab setting, experienced reduced activity, still mobile but needing assistance for all transfers, does have a diagnosis of dysphagia, so does have some swallow problems, and has had input from speech and language therapy. He is reporting that he's actually most comfortable lying in bed, only has a standard armchair at home, and is becoming increasingly frustrated with this inability to interact and engage. So on assessment, some of the postural challenges that we saw were discomfort, fatigue, poor postural control and sitting balance, hemiparesis, so he had weakness on one side of the body that made it hard for him to perform everyday activities, pelvic instability, which was presented as a posterior pelvic tilt, abnormal muscle tone, so he had high tone with spasticity, did present with a foot drop, and increased body weight and size. So in terms of the risks we identified, of course, postural deterioration. If we didn't manage his postural care and he was in prolonged destructive postures, he was at risk of becoming fixed. We could see contractures, we could see things like kyphoscoliosis. Poor physiological function because of his dysphagia risk, unsafe eating and drinking, risk of aspiration, but also infection as well. He was at risk of an increased second stroke because of the increased body weight and size. So a key part of this was really maximising his functional movement, his transfers into and out of the chair to encourage activity. Risk of developing pressure injuries because he was spending a lot of time in bed, because this is where he was saying he was most comfortable, so not getting a regular change of position. Poor well-being, he was already saying about frustration, but at risk then of low mood, social isolation, and the impact that then that can have further on his risk of a second stroke because of inactivity and weight gain. And all of this because of his frustration, because of the psychosocial factors, impacted rehabilitation potential. He was losing that motivation, so we needed to see a change in his well-being, a change in his daily life and engagement to get him actively involved in that recovery process. As I said, we can share all these references and the presentation, but I think it'd be useful now to actually have a look at the seating solutions in practice.
So, 3 chairs with me today. Underneath the umbrella of comfort, if you like, and George's happiness, the key things that stand out for me were fatigue. We need a product that'll help with fatigue, so tilt in space. Pressure care, we need a product with pressure care, or integrated pressure care in the cushions. Foot support, we needed to support George's feet to prevent foot drop. All these chairs have these features, but in a sense, the orange chair you see here with me, the Smart Seat Pro 2, a little bit overly complex for George's need. Very complex back system, very adjustable and supportive, but George didn't really need that. Another key feature that we needed to consider for George was the transfer in and out of the chair. He was transferring in and out of the chair. So we have height adjustment, seat height adjustment on the Pro, but we can do something a little bit more, we can do better, if you like, to help with the transfers other than just rising the seat surface. Tilt in space chair, hydro tilt. We needed to build in some flexibility into the chair. All the chairs have seat width and seat depth adjustments, so pelvic stability is catered for. But with a hydro tilt, you need to swap arms over. Okay. With the multi-adjust, everything we needed for George was built into the chair.
Yeah, though that as Les said, the really key thing was that adjustability because of the potential for weight gain. But obviously, what the health team were working towards and the care team was encouraging activity to try and manage or even reduce weight. So again, being able to adjust the seat width accordingly, hopefully with some weight management.
I'll show you how we can do that in a second. In fact, a lot of the detail in what I'm doing here is going to be difficult for you to see, but if you want to refer to the website, we've broken down into individual segments how we adjust all the chairs within the range. So this is the multi-adjust, and this is the chair we opted for George. Yeah. Fatigue, tilt space, getting gravity to work in George's favour.
Yeah, so it's really good to recuperate for a period of time. Yeah, but as I mentioned, just be mindful with individuals with dysphagia and seek support from speech and language therapy on the guidelines around that to make sure that we can utilise it as part of the care plan and make sure that it's safe and appropriate.
Tilt in space, help with fatigue. Foot plate, integrated foot plate, which is angle adjustable to support George's feet. We can elevate. The chair I have with me today is a manual chair. It's worth considering the benefits of a powered chair for George as well to help with his independence and his motivation to use the chair. Extending leg rest.
Yeah, and again, that angle adjustability really key because of the foot drop. The risks then, like we mentioned, around developing contractures if we didn't support the feet in the plantar position, if we didn't maybe utilise the foot plate as an orthotic device to get some stretching at the ankle, then it could have a huge impact on George's transferability if he can't get the feet grounded and placed on the floor. So really, really key element there, because even in sitting, the feet, I think, often get overlooked in terms of body segment, and they actually take 19% of our body weight. It's a really key body segment for sitting to achieve that postural stability, and in George's case, to protect his activity.
Negative angle leg rest. Now, this is predominantly for somebody perhaps with a contracture. Wasn't really appropriate for George, but where it did help was that with the stand transfers, we could tuck the leg rest away, flip the foot through that so that we got George into a better position to help with that transfer in and out of the chair. Back a little bit. The other thing the chair can do as well, as the tilt in space range is 35 degrees, which is straight back, or we can adjust the chair so it tilts back 30 degrees, but tilts forward 5 degrees. So the chair will tilt forward for us. That helps in so much that it reduces the seat to floor height, and it'll help to lower George's feet onto the floor or onto the surface of a transfer aid to help with the transfer. Multi-adjust with the chair we opted for George, but I think Jess will put a link in the chat to show you the HydroFlex chair as well, which has similar features but operates in a slightly different way. So that will be worth considering as well in this kind of rehab setting. We talked about pelvic stability. George is uncomfortable in his current chair or his existing chair, which is a rise and recline chair. Just couldn't get the right dimensions to provide him with the pelvic stability that he needed to help him function.
Yeah, those chair dimensions are probably the first step in any seated provision that can often be overlooked. And as Les always said, the kind of the devil's in the detail, and actually taking a step back and looking at seat depth, seat width could be that groundbreaking moment to actually getting that pelvic stability.
Yeah, I mean, you know, typically, I think his rise and recline was just slightly too long for him in the seat depth. He's put him into a posterior tilt, and when he was slipping down the chair, he wasn't a happy bunny, really.
Yeah.
You know, he was having to go back to bed because he was uncomfortable. So by adjusting and fine-tuning the chair to the exact dimensions in seat width and seat depth for George, it really helped with pelvic stability. Again, as the detail here is quite close up, just bear with me. Just loosen that off there.
Yeah, if we don't get things like seat depth and seat width right, what we can see is individuals, because we naturally seek that support. So if the chair isn't giving us that support, then for example, with seat width, if we give somebody too much wiggle room, we can see their rotation because they're naturally seeking that support laterally. So we can see a pelvic rotation as they try and get that feedback from the chair. Likewise with seat depth. If the feet are dangling, or if the feet are unsupported, we can go into that posterior tilt to get that proprioceptive feedback that we need. There's also pressure care issues as well when we think about things like shear and friction, if we don't get those chair dimensions correct.
So, you know, ideally we'd set the chair up for George. Hopefully he wouldn't be putting weight on. If he did, you could increase the seat width on the chair. Also adjust the arm height of the chair so that we can just support George in the sitting position, giving support underneath the arm.
Yeah, and a tray can be utilised as well. We'll show you that in a bit shortly once Les has gone through the chair. If by adjusting the arm height, we can give some anterior support as well, especially with his sitting ability and fatigue, maybe with a V cushion on top, just to give that prompting to sit more upright, especially for things like eating and drinking.
Seat depth adjustment. Easy to do, and that just locks off. Just pop the arm back on. George's sitting balance wasn't great. We did try some adjustable laterals. You can see on the chair here, these can be moved up and down, in and out. A little bit overly complex for George's need. Plus, it transfers back into the chair. It tended to not quite be right and just come back on to the lateral. We need to readjust.
Yeah, especially in a home setting as well. If we can integrate as much as possible into the chair, not have any external components that can be misused or lost or used as door stops or bookends. If we can integrate that postural support even better. So that's why we went with something so the contoured
So we just went
cushion instead.
An ideal chair to have in a community equipment store, because you can see how easily we can adjust and modify the chair. So I'll just pop that flat cushion out. And we opted for this contoured cushion. I'll bring it a bit closer to the camera. You can see the shaping there. And what this does is prompt the person to sit into that midline position. It brings them back into midline. Yeah.
But without giving too much support as well, because as we know, a key part of stroke rehab is that activation and getting people engaged in their posture and in their therapy. So we don't want to give too much support either. So just prompting back to the midline, but encouraging him to activate his core as well, to try and rehab as much as possible.
The chair has back angle recline. We need to be really careful about how we use back angle recline on the chair. But it was helpful for George just to tweak, open that angle a little bit, just to help with comfort. Yeah, especially with some of the pressure on the abdomen as well, to try and just open up the hip angle. But just really mindful of back angle recline. So tilt and space, we said about the risk with dysphagia. Back angle recline can really negatively impact on postural stability. So if somebody does have abnormal movement patterns, when we open up the hip angle, we can see some of that shoot through the roof. So just be mindful. In some cases, we might need to set back angle recline and then lock it off as Les will go. So tilt in space is top right. Just squeeze, release, and adjust wherever's most appropriate, most comfortable for your client. Back angle recline, we've got this locked mechanism here. So we don't want to make it an accident waiting to happen, in a sense, where somebody inadvertently adjusts back angle recline. So hopefully somebody comes to the back of the chair, squeezes both handles, tilt. Yeah, that's okay. That's posture neutral. Doesn't affect the way that person sits in the chair. You squeeze this lever and nothing happens. That's because you need to unlock it. Little clip here. Squeeze, adjust, and as I release it, you'll hear it lock back. That's in effect locked in position. Head support, what we found worked best for George was a soft profile headrest, which is this shape here. It's a soft filled headrest, which we can open up the back and move some of this padding around. Something we considered was what we call a tailored solution. So it's a bespoke modification to a component of the chair, to a part of the chair. And what we did with the headrest was to segment the headrest into 3 sections. So that meant we could take the padding out of the middle section and make the 2 wings more prominent. Again, prompt George to sit in that midline position when he was in the chair. I can just snip on. The other component that we opted for was a tray. Tray sits on the arms of the chair. 2 benefits for George here. One is the obvious functional, for reading on my iPad, remote control, lunchtime.
He did have some aspirations when we talk about personal goals as well, and getting people involved and motivated to return to some form of occupation from home. So if he didn't have a tray, then that could have really severely impacted his ability to function within the chair. But also in terms of posture, it helped to open George up a little bit. Yeah, the anterior support can be really good because he was at risk because of the of developing that kyphotic posture. So giving that anterior support and that prompt to open up the shoulder girdle for physiological function, but also protect the body shape as well. We did consider pelvic straps and positioning aids, but we didn't really need those. If they were needed, they could be fitted at a later date. So with the tray, contoured back, soft profile headrest, foot plate, pretty much the chair that we supplied for George. Yeah. With the water cell technology as well. Yeah, the pressure care and the seat surface as well. An option we considered, but it's like everything in specialist seating, there's a level of compromise, and that would have been contoured seat cushion to help support the upper legs. So you can see there's a ramp at the front edge there. This is really good for getting the thighs in alignment. Contour there to help with thigh alignment. But as you can see with the ramping of the seat, it was a little bit difficult for George to get up and over for his transfer into the chair. So that was a little bit of a compromise situation. We stuck with the basic pressure care cushion, the water cell technology cushion that we use with the chairs as standard. Yeah, and obviously you hand over to monitor that to make sure they're still effective as part of a regular repositioning program in managing that pressure risk. And that was George. I think I've covered all the features. Yeah, and we spoke the powered options as well. Yeah, powered options, there'd be, we could fully motorize the chair, which would give us powered tilted space, powered back angle recline, and powered leg rest elevation. Powered back angle recline can cause us a little bit of an issue sometimes. Yeah, it's a bit too easy, as we said. It's a bit too easy, and it really does depend on the person sitting in the chair having the ability to reposition themselves. Because we open up the back angle, we go into like a posterior tilt, we close the back angle. What's happening is that's the person sitting in the chair, that's the back of the chair. It's crunching them down. That happens as we open up the back angle. As we close the back angle, they need to be able to reposition themselves in the chair, and more often than not, they can't do that. So we tend to, as we did with George, set the back angle, lock it, and kind of forget about it, really. Probably worth mentioning as well, Les touched upon it about tailored solutions. Because if you are talking about stroke recovery here, there is going to be a vast range of individuals from mild all the way through to highly complex presentations, especially if maybe they've been lacking that care or support for a period of time and they have developed contractures. There is a whole host of modifications that can be done, with the beauty of it being on site in Devon. Yeah. From basic, as Blair said about the headrest, basic accessory changes, all the way through to modifications, the actual frame of the chair, split leg rests, special laterals, specially shaped laterals. Perhaps we've got arm height adjustment built into the chairs, but there may be a need to have one side, perhaps a hemi Yeah.
Hemi tray.
Yeah.
Yeah. A pommel can be fitted to the chair as well. Maybe that, if somebody has a drop foot, it's very difficult to get somebody's foot supported evenly on a flat foot plate. So sometimes we look at a soft cushion foot plate.
Yeah. Split seats as well. So if somebody has developed a pelvic rotation has become fixed, or if there's leg length discrepancies, if there's subluxations or dislocations, split even down to split bases. Docking cushions, we said about pressure care, about water style technology. If individuals do have a particular third party need, so if tissue viability been involved and there is a third party cushion, docking cushions, because it's all about integrating it into the chair rather than just putting a cushion on top of the cushion. You focus on George, but if you have got individuals who are more highly complex, we did touch upon the Smart Sleep Pro 2 as well. Yeah, but we're open to a question. I think we've actually finished a little bit over. Yeah,
a little bit over. We don't quite well. We normally, Rebecca goes off on a tangent. I think we can take some questions.
Yeah, definitely.
Yeah, do we have any questions out there, Jess?
So we have a question. Do we rent chairs to clients who may require private purchase due to the delay in funding?
It depends on the specification of the chair. It can be done. We also loan chairs for trial periods. So if we know that somebody has a particularly complex need, or we need to try something out, perhaps with a wider group, the carer group, we can loan a chair for a few days just to see how they get on with that. Yeah, it depends on the specification of the chair, though.
It's a really good way for data collection as well, that trial period, especially with funding justifications and funding requests, to really use that opportunity to get data on the effectiveness of the chair as well to help with that clinical justification. And
we work with a partner network as well. So broadly speaking, the answer is yes, we can hire a chair when somebody's waiting, but it depends on the specification of that chair as well.
Things like tailored solutions, things like that are needed, and obviously adds a bit more challenge to it.
Do you also have any information about 24-hour positioning in the acute setting?
I mean, probably that webinar is probably, I mean, it's the same application really, whether we're in acute settings or whether somebody's been discharged back home. If it's long-term support, that 24-hour process is going to be the same holistic approach that's needed. And in the simplest of terms, we just look at all those activities within the 24 hours and how do we achieve different postures to get a regular change of position. But certainly that webinar with Simple Stuff Works is probably the best starting point as a basic introduction to 24-hour postural care. It is going to be completely individualized then depending on their needs. It can be a bit more difficult in acute settings. I understand those challenges, especially maybe with staff turnovers, with staff shortages. But it's just really about looking at our full 24 hours and how do we get a regular change of position. Especially maybe even, I mean, sometimes it's frowned upon in terms of going back to bed for a period of time, but actually if that's the only other piece of equipment that somebody has, it's best for somebody to be in a seated position for a period of time, go back to bed, maybe side lying if it's possible, high sitting, supine lying, prone lying to get a change of position, but then come back to sitting. So it's just about looking about what's available and doing what we can really with the staff that we have, with the care team that we have, with the equipment that we have. But definitely as a starting point, have a look at our webinar, and then that might just help guide maybe some of the basics that need to be achieved.
And you know, if you still have a query, just drop us an email and we can, if not answer it ourselves, put you in touch with the right people to kind of take you forward with it.
Thank you. And how long do you recommend the client to sit in the chair for?
Oh, it's
how long is the string? Yeah. Completely depends on the individual. I mean, if somebody has quite a high pressure injury risk, you could be talking 15 minutes. And somebody needs to change position. Some individuals can tolerate it for 4 to 6 hours.
I think it's part of the assessment process is to establish expectations and what's realistic, because you know there's occasions where we call back to say that somebody's not comfortable in a chair, so we go back to review and we ask the question, how long do they sit in a chair? 4 or 5 hours at a time. Well, is it realistic to expect them to be comfortable for 4 or 5 hours at a time?
Especially in a new piece of equipment when they've been used to being in bed for so long. It's about that. Anything to do with postural care has to be a gradual, gentle approach. And regularly reviewing that for a period of time. So on the first day, we might start with half an hour, and if they tolerate it, we then work our way up.
Because we do work with people who've been in bed for 18 months, 2 years. So to expect somebody to go from a supine lying position, or even if you're sat up, into seating for 4 or 5 hours at a time, it's not often realistic to do that.
Yeah, but again, we can support you if there's specific cases that you're concerned about. When you do joint assessments with us, that's something we can support with anyway. But it completely depends on the individual, what their pressure injury risk is, what their comfort levels are, what their tolerance is to being sat upright, their other needs with eating and drinking. Do they need that more regular change of position for comfort, to reduce the risk of contracture? So yeah, it's a difficult one to answer, but some people are going to be 15 minutes all the way through to 4 to 6 hours.
Depends on the individual. There's no absolute answer to that question, really.
Do you also have any advice on approaching nursing homes for funding, particularly with people who could be end of life but still require pressure care, breathing, minimal function, etc., to avoid being in bed most of the time? And do nursing homes, in your experience, support your requests?
Again, depends on the nursing home, depends on the area of the country. You could travel 2 hours down the road and have a very different experience with a particular group to somewhere else. Yeah,
and I think sometimes the wording in the legislation is a little bit vague. Reasonable or appropriate seating. So what is that? That judgment varies depending on whoever's reading the documentation. The best way that we find is education. We try to involve ourselves with care homes and nursing home groups to really push the benefits of postural care. Yeah, especially for the staff, for working practices, easier manual handling, less time spent, reducing the risk of needing to increase care packages. All those benefits, rather than particularly the individualized benefits as well, can sometimes help. I'm doing it from, as I said, from that angle, how the chair can benefit working practices. Just general improve the well-being of the resident.
How the chair can be utilised, maybe one chair between it, maximising it for different individuals, and making sure that they are competent in being able to change things like seat depth and seat width, so there's less of an expense rather than needing different chairs for different individuals. I mean, the last resort, if you are really struggling to get somewhere, we have worked with health and social care professionals where we've had to really push the legislation when we talk about things like avoidable harm. If somebody highlighting those risks and consequences, we've done a lot with clinical justifications as well. So if you need support around that, but really just highlighting and making sure that the nursing home group that you're working with are aware that that's their risk that they're taking on. You've highlighted the need for specialist seating. You've highlighted what the risks and consequences are if they don't get that specialist seating, and our responsibility is back on them. And there's now obviously legislation in place when we talk about the new acts in place and things about reducing the risk of avoidable harm. We have worked with some individuals who've gone down safeguarding routes as well, as a last resort if it's something that is really a need there. But again, completely individualized. So if there is a particular challenge, then yeah, get in touch and we can have a look.
We will support you in any which way that we can in terms of training and awareness and just to generally promote well-being and postural care.
Yeah, it's just about highlighting and using our words very carefully as well, because it's all very well as going to a nursing home or a care home and saying this chair is needed, but as Les said, our education, making them understand why it's needed and what the risks are, and actually do they want to take that risk in not providing something. Because if somebody is having repeated aspiration pneumonias and ending up in hospital, what that means when we talk about things like stroke recovery, especially when we said like a fifth of those with ischemic strokes then develop pneumonia, and at the risk of then that comes with avoidable harm and the safeguarding issues and so on. So it's just using our words, using that evidence base as well, and making that clear that our responsibility is away from us as health and social care professionals, and actually on them to put that in place or not.
Any more, Jess?
I believe that's all of our questions for today.
If that's the case, it just remains for me to say thank you for attending, and a big thank you to Rebecca. You may have noticed Rebecca is
Carrying a bit heavier.
Yeah, it's actually Rebecca's last webinar before she goes off on
Yeah.
maternity leave. So it's a big thank you from, not just from me, but from everybody at CareFlex. And I'm sure there's lots of people out there that'd like to say thank you for all your efforts
Thank
over
you.
the last,
Thank you.
God knows how long.
Yes, and hopefully we'll be back soon.
Yeah.
The webinars are going to continue. We got our plan in place. So as always, there's going to be a break over the summer. So Les is going to be facilitating the next one in June, and then there'll be a usual break over summer, and then there's a plan in place then for September, October, November, and then I'll hopefully see you in the new year. Then.
So watch this space. The webinars will be continuing,
Yeah.
just in a slightly different format. So thank you very much. Thank you all for attending. Hopefully we see you sometime soon in the flesh. If there's nothing else, I'll wish you a good day. Thank you very much.
Yeah, enjoy the sunshine, hopefully.
Cheers. Bye-bye.
Bye.